Today, our guest is Level Funded Health. And Doug Austin, our CEO, is here to kick things off in just a moment. We'll have a series of poll questions and a post-session survey and a lot of good content. So let's get things going now with Doug.
Welcome, everybody. We're glad you're joining us today. Thank you. I am pleased to present good friend and alliance partner, Russ Carpel of Level Funded Health. Russ is going to talk to you about health insurance, which is one of the major expenses in any organization, certainly in the dealership space. And we'll bring Russ on in just a second. We've got a slide up right now. If you're interested in a copy of this deck, just scan this QR code. We'll make sure that we get that off to you right away, and Russ will be able to answer any questions that you have. We started this webinar series about 3 years ago, and in the course of that, we've presented on numerous topics, including various expense categories, of which health insurance is certainly one of them. But we've also presented topics of audit and recovery and even new revenue opportunities, all intended to reduce expense and improve profitability. We have various topics. A couple of weeks back, we did one on aircraft finance. A couple of weeks before that, we did one on buy-sell. So if you're new to this series, we encourage you to stay tuned and watch for other topics that are coming up. But with that, I'll turn it over to Russ. Russ, take it away.
All right, good deal. Well, I appreciate everybody hopping on today to talk about how we can improve profitability and EBITDA. As I really like to explain to everybody and that we come across, and I think most of you on the webinar probably know this, healthcare is typically, from what we see in health benefits, I should say, the second or third biggest line item expense for most dealers and quite honestly for most businesses, regardless of industry. We do a lot in and outside of automotive retail, but our passion is really within auto retail, and really don't want to make this a commercial about us, although we are going to show you our TV commercial, no pun intended there, but really talk more about healthcare. That's really truly our passion, and my passion personally is not only health insurance, but healthcare. Everybody always talks and complains, and rightly so, about the cost of health insurance. But if you don't really attack the underlying costs, which are the costs of the care itself, you're not really doing anything to bring down your health insurance, because the health insurance is just there to make a margin on top of whatever the cost of care is. So one of the big things we've pride ourselves on, and that I'm personally passionate about, is really attacking the 10% of your claimants that are driving 90% of your claims dollars, which is pretty much the case with any group that we ever come in contact with. So the focus, in my opinion, should never really be health insurance. It should be the underlying cost of care, which is pharmaceutical companies, PBMs, hospitals, things of that nature. So with no further ado, I'm just going to skip on to the next slide here. So just a really quick about us. We're a national broker, but we're much more than a traditional broker. So we call ourselves a direct-to-employer tech-enabled commercial benefits distribution platform. Our goal since we started 10 years ago has been to commoditize the commercial health insurance space using technology, but more importantly with innovative products that can deliver dealers and other businesses outside the category on average about 22% savings, which is what we typically see. We work with over 60 A-rated national stop-loss carriers, also known as reinsurers, which is really unique to the self-funded and level-funded and captive space, but we also work with fully insured carriers as well. So a number of things that make us different, but I would say our expertise in and around self-insurance is a big deal for what we do. We have national partnerships, of course, with Doug at StrategicSource and his team. They do great work. A company called Priority Payments, DSMA, and many, many others in the space. So we're going to just do a quick poll. It's helpful for us to know who's on today. Okay, so David is going to share a quick 30-second spot that we ran, TV commercial, that we used to air quite frequently on CNBC and Fox Business News. And it's a little more focused towards a smaller business. But since we created the spot, we've definitely, over the last 10 years, pivoted more in the middle market. But I think it'd be good just to get to know us a little bit real quick.
Okay, let's roll.
Thank you.
Attention business owners. What if there could be a way to provide outstanding health benefits for 20, possibly 30% less than you're currently paying today for your business health insurance? And that's not all. What if, with these same benefits programs, your business could potentially qualify for an end-of-year refund? Best of all, what if you could switch into one of these programs at any time without being subject to the typical annual ACA renewal periods? Call or visit us online now to see how much you could potentially save.
Okay, thanks for that, David. I'm going to move on. So that's just a little more one-on-one on us. So one of the big things that is, I think, frustrating for many dealers and CFOs, CEOs, HR folks, benefits people, there's really a lack of fiduciary duty on behalf of these intermediaries, or AKA health insurance brokers. The thing that I find kind of interesting, if not very frustrating for myself, and especially for people on the other side of the desk on the client side, is that in the 401k space, maybe about 10, 15 years ago, there was some regulation that came down on the federal level by ERISA and FINRA and the Department of Labor that says someone in the stack, whether it be the intermediary, the broker, the financial advisor, the CFO, someone has to act as a fiduciary and make sure that the employees and the employer are getting the best product for the best price on the 401k side. And 401k is similar in that it's an employee benefit, but on the health benefit side, which is a much bigger expense for the employer and the employees, there's really no true fiduciary duty, that has been pushed down from either the state Department of Insurance or the federal ERISA or Department of Labor or FINRA or anything like that. So I think that is one of the things to keep in mind is brokers, TPAs, carriers, unfortunately, are not always rowing, I would say 90% of the time, not in the boat with you, rowing in the same direction. Very much almost like real estate, where they tend to push the highest premium plans, and they're allowed to do this. And so they're capitalists just like the rest of us on the call here. So it is what it is, but it's very frustrating in that they're usually not solely representing the client. They're more slanted towards selling on a commission basis for the carriers. And the result is they're going to push the highest premium plans that are going to result in the highest commissions possible versus working on a flat fee. There are a few exceptions like our firm, but the majority are still working in the old fashioned way of doing business. And the more business they send to one particular carrier, the more bonus or AKA override they'll get. So I always challenge everybody to try to look and talk to your brokerages that you deal with, your outside consultants, and find out if they work on a flat fee or if they're still taking a commission on the lines of insurance, especially the healthcare line, because that's obviously, like I said, the biggest second or third biggest line item expense for most businesses. Okay, so we're going to do a quick poll to ask you all if you're fully insured or self-insured. So it looks like we have over 60% fully insured and almost 40% self-insured. Relatively small sample size, but not surprised to see that. In the middle market, small to middle market, you definitely have, and I'll share these results, you still definitely have, I would say, 60 to 75%, depending on what data set you look at, 65, 75% in the small to mid-market corporations, not just within automotive, but in all industry verticals that are still fully insured. And we'll get into a little bit about the differences of the two. Some people may know some of the differences and some may not. So I'll share those. One more slide, and then we'll get back to some of my talking points. So what is your current claims to premium ratio as a percentage? Those of you that are fully insured, you may or may not know this. You will know this if anyone shared it with you, your broker or CFO or benefits person or carrier. When you're self-insured, everyone gets this data. When you're fully insured, you have to have 100 or more enrolled, unless you're in an anomaly state like Texas, where the Department of Insurance has mandated that you get the data even under 100 enrolled. I also find it, is why people are filling out here, very fascinating how many people have access to the data. In many cases, but the broker or the TPA or the carrier has never even brought it up. You always want to be doing, if you do have data, that's the first thing to figure out. If you do, you always want to be doing at least quarterly claims reviews to see what's going on. You'll never know what's going on with a particular claimant by name. They'll obviously code that so you don't know who has what prognosis or diagnosis, but it's always good to analyze the claimants and figure out, you know, where those dollars are going to what facilities, what hospitals, and what drug companies and what drugs specifically, because there's things you can do to optimize that on the back end. So I'm going to share the results. Looks like the good news is for people that have answered, the majority of you have loss ratios below 100%, and only a couple, it looks like maybe just one above 100%. So if you're running below 100%, you're running pretty well in the eyes of the carriers and the stop loss markets that we work with, which could mean that you're potentially leaving a lot of money on the table. So I guess both good and bad news, but primarily good news because there's an opportunity to trim potentially a lot of the fat. But obviously every case is different. So I'm going to share these results, then we'll move on to the next one. All right, so just a few more slides and then we'll open it up for Q&A. So some noteworthy items that I just wanted to mention today. Healthcare spending in the U.S., it's really flabbergasting, but as a percentage of the GDP, it's actually 20% and rising by all the data that I've seen out there. In my opinion, and I think in many that I know in the industry, healthcare is truly one of the most crony, collusive capitalist markets I've ever seen and probably in the history of America. Unfortunately, providers such as drug companies and hospitals, fully insured carriers, these networks, and everybody up and down the stack alike, all the middlemen, set prices on the service itself and procedures prior to the customers even getting their health insurance card in the mail. It's coming from these providers and facilities that have already struck deals and drug companies on what that reimbursement scheme should be. There's really no true free market. The only place you really see a free market in healthcare today is really around cosmetic and elective surgeries, whether that be Botox or LASIK, for an example, where there's no insurance accepted and the providers are then empowered to show the price in full transparency, and the other side of the table, the consumer can actually shop around for care and has an incentive to do so because there's no quote unquote network that's established. The networks, unfortunately, are causing a lot more harm than good. They've been around forever and everyone's used to the concept of a network. In my opinion, that whole model needs to be blown up, and we're doing many things to kind of get there, but not fully. The industry's not quite there yet, but getting away from these backroom deals is critical. There's a great book called America's Bitter Pill that was written right around the time the ACA and AKA Obamacare came out by Stephen Brill that I would recommend everybody read if they ever have some downtime and have interest in learning more about the space and the backroom deals. But the industry is unfortunately, just overwhelmed by these types of backroom deals. So that again, the primary reason why healthcare insurance is so high, again, is the underlying cost of care continues to skyrocket. I actually just saw an article as of yesterday that all the major health insurance companies, not that we should feel bad for them, but just the facts are that they were revising their guidance on their earnings, all these publicly traded health insurance companies, and their margins, I should say, because the underlying cost of healthcare that they're paying out on the other end, it continues to go up. So again, not just the insurance company's problem, it's or cause, I should say, for these increases that you all are seeing. It's really also, if not more so, the doctors, the hospitals, and the drug companies. Drug costs are on pace to reach 50% of an employer's total claims as a percentage of total claims within the next 5 years, if not sooner. This is actually completely mind-boggling to me. When I started this business 10 years ago with my team, we were seeing about 15% of a client's overall claims going to pharmaceutical drugs and pharmaceutical companies and PBMs and things of that sort. But we're now seeing our clients anywhere from 20 to 30, some cases 35%. And obviously we'll do whatever we can to knock that down, but it's going to reach a tipping point soon where it's going to be 50%, if not higher, of your overall claims are going to be going to drug costs. And there's a number of reasons why that is. And there's also back to the fiduciary duty. Unfortunately, not a lot of brokers, TPAs, or stop loss carriers or fully insured carriers are doing much to attack this cost. And there are actually some very simple things that can be done, but the lack of fiduciary duty is keeping drug costs very high, and also as a very high percentage of overall claims. So it's quite disgusting to me personally, because again, going back to the backroom deals and everybody in the stack making exorbitant amount of money on drugs that employers are faced with and their employees, and none of these commissions are even transparent on this side of the house. You may get some transparency on the medical benefit side, but when it comes to pharmaceutical drugs, there's very, very, very little price transparency of what's happening and who's taking commissions. And again, no regulatory body has cracked down on this yet. We have seen Congress attack the PBMs, and that's great, but the PBMs are only one of many, many layers of fat in the drug supply chain. And so I won't go into too much on this particular topic, but it's a huge, huge problem that's just going to continue to bubble out of control. So moving on from there, whoops, sorry, I skipped a slide, everybody. Go back. Okay, so if you're self-insured, the next question we have for you, are you vertically aligned? Meaning, does the same company that has your stop loss, or AKA reinsurance, also function as your TPA and your PBM? And the PBM is the company that gets you access to drugs. And the TPA is the third-party claims administrator. And then the stop loss is the reinsurance behind your limit. And for I think only one or two were fully insured. So the majority of you on the call, this should be relevant and applicable. So again, if you're self-insured, are you vertically aligned? And again, vertical alignment is if you have the same exact company for the stop loss, the PBM, and the TPA. And I should also mention that, I should have mentioned this before the poll, if you see a company like CVS and Aetna, they have their own PBM, and it's branded as CVS Caremark. So some people may not know on the surface that they're all owned by the same holding company. In the case of Blue Cross, they have their own PBM called Prime. Cigna has their own PBM called Express Scripts. So I apologize. I should have preferenced that before the poll because some people may, in fact, think they're not vertically aligned, but they really are. And the reason why I brought up PBM is because PBM is one of the biggest profit centers for these companies in these situations when you're self-insured and you're using them for the TPA and the stop loss, both of which are truly a commodity where they're bearing a lot of the fat. Significant amount of the fat typically becomes in the PBM bucket. So I don't know how reliable the results are given what I just said. I'm going to assume that's probably like 50-50, if not 70-30 the other way after what I just mentioned. But either way, I really just wanted to educate you on this point anyway, so not a huge deal. So I'm going to move on from there. And just to actually touch on that point, I'm not a fan personally, for what it's worth, in my 2 cents, to be vertically aligned. Anytime you're vertically aligned, obviously fully insured, you're 100% vertically aligned. When you're self-insured, you do not have to be vertically aligned. And if you get away from the vertical integration, you can save tremendous dollars. But obviously you have to go with the right providers when you do that, and it creates a lot more work for the broker, but not so much for the employees, and they see better outcomes at a better price. Okay, so one more poll and then just a couple last slides. I appreciate everybody, and then we'll get into questions. Are you getting transparent monthly and or quarterly claims reviews from your broker or your TPA? This is critically important, especially since it sounds like most people are self-insured on this call. It's like the majority of people are not getting claims reviews, so that's definitely somewhat of a red flag, and something that needs to be addressed, in my opinion. So I'll share the results really quick, and we'll move on. All right, so this is interesting. Self-insurance is, level funding is a version of self-funding, hence the name of our firm, Level Funded Health, which we feel we're experts on at this point, been doing this for a long time. We got into this space 10 plus years ago and created this firm with a lot of veterans from the industry that have deep expertise in self-insurance. The reason we did it was because we saw that the ACA, aka Obamacare, was really starting to cause a lot of problems in the fully insured market and the fully insured pools of risk. I won't go into all those issues. There's not enough time, and I don't want to bore everybody with all the details and the jargon. But I will say that what's very fascinating is that 100 million Americans, 1 in 3 Americans walking around the street today, are on a self-funded benefit program, and they don't even know it. And the reason that is because their employer is saving a ton of money, and usually employers are not paying 100% of the benefit from a contribution standpoint, as we all know. So the employees and their dependents are saving a ton of money as well. They save collectively billions, if not trillions, by self-insuring. And all your big businesses, unions, governments, municipalities, universities have been self-insuring for years. Your Fortune 1000. When we first got in this business 10 years ago, 90% of employers that had 1,000 or more employees were self-insured. And this is an interesting chart, I believe, from Kaiser Family, which is one of the respected data sources in the space. You can see as the number of employees in these little subsegments, if you will, the number of self-insured groups goes up. And every data or survey source I see out there is a little bit different, but it predominantly has always been 1,000 plus employees. Our intent has been to also make it available for lower middle market companies, and I'm defining lower middle market by anywhere from, let's say, 100 employees all the way up to 5,000 employees, and that's really been our focus. And we've, over the last 10 years, definitely, we've been one of the pioneers, I would say, in pushing people over in this direction. At the end of the day, we try to act as close to fiduciary as possible. We don't really care if an employer is self-insured or fully insured. But what I will say is that if you're over 100 employees and you're not exploring self-funded strategies, you're probably getting done a disservice by somebody up and down the stack. Once you get over 100, and sometimes even below 100, but definitely over 100, there's enough diversification in the risk pool to where it makes sense to at least compare your options. And once you do that, you have the ability to truly attack the healthcare cost. We don't have enough time to go into how that's all done on this call, but until you get into a self-funded structure, you can't attack the vertical integration, and you cannot attack the underlying claims themselves and attack the providers and the hospitals. And maybe attack's not the best word, but negotiate with, if you will, rather than attack. So I'm going to move on from there. Okay, whoops, sorry about that. Poll 6. Okay, so how significant was your most recent renewal increase when it comes to health benefits specifically? So we're not talking about dental or vision at this point, really just talking about health benefits. So this is our last poll. And the answers are 5% or more, 10% or more, or 15% or more. And by the way, we've seen much higher than normal over the last year and a half, and when it comes to renewals, given I think some of the risk pools have not been performing well with some of the carriers, especially in the fully insured side, coming out of COVID. A lot of people delayed care, that caused some big claims, and COVID itself obviously caused some claims on many fronts. We didn't mention if anybody saw a decrease, and we could have, but typically it's never seen. That's actually not to boast about ourselves, but that's one of the things that we pride ourselves on is coming in and actually providing a decrease versus an increase. So we're going to move on from there. Okay, so I think that's all we had in terms of content, and I know there's a good handful of people on today, but not an overbearing amount. So I definitely wanted to make myself available for any Q&A, and I think there might already be one or two, if I remember correctly, David.
Yeah, we're all set for Q&A, everyone. There's a Q&A button at the bottom of your screen, and you can ask questions. Those will come directly into Russ. And we can have Doug come on too in just a moment to be part of the Q&A.
Yep. It looks like we've got a question from Craig. So I'm going to answer live. Hopefully everybody can hear me. So it says, what is your success ratio in rural areas with non-traditional health plans? So I don't know, Craig, if you're asking about self-insurance in general or just alternative structures in general, but I will say we've definitely had a lot of success in our firm over the years in the rural areas. Is it a little more challenging if you want to do something really out of the box? I think I may know where you're going with it. 100% it can be, especially when you have hospitals that are dominant in a particular market. Doesn't mean there are things that, and when I mean dominant in a particular market, hospitals, meaning they may have 2 hospitals in town in a rural area or within a certain radius, but they're owned by the same holding company. Obviously, they're going to dig in, but that doesn't really affect prescription drug distribution, and that's another really huge place to find savings. And it looks like a follow-up on that is getting away from BCBS and moving and going with self-insured and going provider network in a different TPA and drug provider. Yeah, so getting away from Blue Cross, BCBS, or any big BUCA carrier, BUCA, the acronym Blue, United, Cigna, or Aetna, in my opinion, is always a good thing. And it sounds like you may be, in this case, fully insured and going to a self-insured model. 100%, I think it's a smart thing to do. Obviously, you have to do the due diligence, and there's a lot of different directions you could take that. But being in a rural area, you have to really have someone that really knows what they're doing, not just in that rural area, but nationally as well, because you're also going to have employees traveling and on business and pleasure. But the good news is, yes, I would say for anybody, whether you're rural or metro, and you have at least 100 employees on the plan, I would always recommend getting away from fully insured that is vertically aligned or self-insurance that's vertically aligned. And there's a lot more nuance to it, but the good news is, yes, there's a lot of opportunity there. Obviously, you have to do the due diligence for someone like us to really make sure, but 99% of the time, it's a very smart thing to do. And thanks for the questions, Craig.
Yeah, I have one here that I wanted to have you elaborate on just a moment.
Okay.
Could you talk about people concerned about what they should be doing to drive down the cost of healthcare within an underlying plan?
Yeah, 100%. So I touched on it a little bit. I think, and I don't want to, keep beating a dead horse because I mentioned a lot of these concepts already, but I think the big thing is to move away from being vertically aligned, move away from being fully insured, trying to get in that self-insured bucket of the way you do business, and then get away from the vertical alignment, have an independent stop loss carrier, an independent TPA, hopefully a broker that's on a fee basis and not a commission, a PBM that's not owned by the BUCAs. So that's a lot of different things I just rattled off that are not so easy to just rip the Band-Aid off if you don't have somebody that really knows what they're doing. But doing all that and then really keying in on those 10% of your claimants that are driving 90% of your claims, what drugs are they taking? What are the diagnosis of these folks? Can we source those particular drugs cheaper somewhere else from a different provider, that is, not meaning out of the country, but from a different provider, a different supplier? Can we put pressure on the current suppliers to bring those costs down? A myriad of things, and then also looking at those hospital reimbursements. The biggest area where you can move the needle is going to be in pharmaceutical drug costs and in hospital and outpatient facilities and procedures. So that's really where we want to key in. And if we don't have access to claims and we're not self-insured or not self-insured, it becomes a big challenge. And we've got another question that just came in here. Some of the healthcare providers have indicated that a non-BUCA provider is not really insurance and you may have to pay up front for care. Yeah, so I think I know where you're going with that question as well. BUCA meaning Blue, United, Cigna, and Aetna. So those companies, the BUCAs, they own their own networks. They're also insurance companies, but they've built these great, one thing that they're actually good at, that in my opinion is building out these networks, and they've built them out over the years. Even though the networks, I said before, cause a lot of problems, they also play their role in the way the market's set up today. Now, I think I know where you're going with this question, which is if you move away from a PPO that's BUCA and you have a custom network built, or maybe even reference-based, that it's not really insurance, you may have to pay up front. So yes and no. It's probably more for a one-off discussion because it's going to get pretty in-depth on this answer. But I will say that that what they're saying to you, it's not really insurance, is in fact not true. It's just that it can be a little clunky when you don't work with a Blue, United, Cigna, Aetna. And what I will also say is that you want to be careful, especially in a rural area, with getting away from a BUCA as a network, but not necessarily BUCA as the TPA or the stop loss carrier. It can be done, but it requires a lot of work and preparation for the employer, the employees, the TPA, the broker, and it should not be a decision just made off the cuff just to save money, in my humble opinion, because it can, for the incremental savings, it can cost a lot more headache and disruption and frustrate employees if it's not done the right way. And unfortunately, most of the time, as novel as some of these concepts are, the people involved of executing them are really not the greatest. And so I would say that there's alternative ways to do it and maybe dip your toe in that self-funded in a different way, and then maybe go into something like that downstream as you get comfortable with these self-funded out-of-the-box concepts. But I don't really agree with the provider's statement that it's not insurance. It is insurance. It's just a little more complex, if that makes sense. And it can cause balance billing as well.
Well, thank you, Russ. For those in the audience, and I recognize some of your names, I can't think of anybody more creative, more innovative on the healthcare side than Russ Carpel. So I would encourage you to reach out to Russ with any contact or questions that you have. His contact information is there. We will have a copy of the webinar on our website probably before tomorrow, I would think, or no later than tomorrow. And we can make, again, copies of this available to send out. But Russ, thank you again.
Thanks, Doug.
You've done a great job and in a very complex expense category, but you've taken some innovative approaches here, not only on the healthcare side, but on the pharmaceutical side as well. So don't overlook that component, because Russ can help you there. So scan that QR code, give us some of your information. We'll shoot that out to you and you'll be all set. Thank you, Russ.
Thanks, Doug. Thanks, everybody, for joining.
So for anybody who's thinking about their expenses right now, the question is, how much money are you leaving on the table? There's a group out there called the Aberdeen Group that does a lot of research that says most organizations are leaving 25% of their spend on the table every month, which and we know that in the dealership space, dealers are spending 5% of sales on a consistent basis. So if you're a $100 million dealership, you're probably spending $5 million or 5%, and that 25% looks like about $1.25 million on an annual basis. We know that there's about 150 expense category options out there where you can spend money. Most dealers will spend in roughly 100 of those. And again, those, that $5 million should be spread among those 100 expense categories, and 25% of that is available. So there are 95% of the dealerships in the United States, based on the work that we've done and what we know, are decentralized, meaning they do not have a purchasing department. StrategicSource can be that purchasing department for you. We have a lot of experience in analytics. Certainly in the expense categories, we will have probably accomplished 2,300 sourcing projects last year. But the business problem that dealers have is there's a broad group of categories. They tend to approach this in a very tactical firefighting approach. We know they're short-staffed, and there's typically not a category plan to attack. So this just shows from a top-down, dealers are overpaying for supplies, 25%. There's a broad scope of categories. There's too many suppliers to manage. There's too many supplier invoices to process. There's few discounts and rebates taken. And the question is, the challenge is, how do we simplify that? So this just shows what the annual savings might be on an opportunity for different size revenue groups from 25 million to 300 million, and what that savings can look like on a monthly basis. Remember that cost savings drop to the bottom line. So it's an immediate impact on profitability. Expense category scope, just touch on this briefly. There are 72 categories, regardless of what business you're in. If you're a dealership, if you're a church, if you're a manufacturing company, a service provider, you are likely to spend money in these 72 categories. If you own your own facility, or even if you're leasing, you are probably paying for these 15 facility-related categories. And if you're an automotive dealer, there's another 56 expense categories there. So you can see how that scope of work is quite large, up to 130, 150, and it can be a little bit overwhelming. So we have some solutions that can help. We have a profit improvement program where we will conduct a financial analysis. We will do some spend category planning. We will do some sourcing, category implementations. We'll review, we'll manage that process. And then number 6, we will audit the suppliers as well. So the problems we solve, really high expenses, broad supplier bases, we can help you rectify that. The other thing that we can provide is a strategic spend analysis. This is more of a strategic look, a broad look at your expenses. We can analyze them. We can put them in the right category buckets and end up building a plan for you to exercise or for you to execute. Again, the client benefits, it's a prioritized plan. It's a good staff planning tool, and with the idea that we can help direct you to a 25% savings. We have a contract tracker tool. Most dealers have contracts. Most of them don't do a very good job of managing those contracts. We've got a tool that will provide that, not only the management, but it will tip you off with alerts. The contracts are coming up and need to be renegotiated. We've got a spend management suite that kind of combines some of the digital solutions, if you will, the tracker, Expense Edge, which is really analytics. We've got coaching available, and certainly spend management learning. We do a lot of training in the spend management area, and we can train your team as well. And then last, Expense Edge, this is based on our database of thousands and thousands of price comps. This is kind of similar to Home Depot. We can provide the tools and solutions. You do the work, but we can give you the data points to keep your costs down. Spend management learning, again, we can teach your team to do what our team does. We have trained many folks. We do many webinars a year in purchasing 101, 102, 103, and we can help you develop your skill sets there as well. So hopefully this has been a helpful presentation today. Again, use that QR code. We'll get information off to you right away. But thank you for joining us. Thanks again to Russ and his team. They've done an outstanding job. Again, we don't take any compensation from suppliers, so we really have no skin in the game, but we do know them. We have vetted them. We know what their work product is. We know how competitive they can be, and we'd encourage you to take a deeper look. Thanks again for attending today. David?
All right. Thank you, Doug. And thank you, Russ, and everyone for attending, taking part in the surveys, the poll questions. We have a survey now that we'd like to bring up on the screen. 2 questions just to get your feedback on the time spent, because your input that we get, it makes us better. So we appreciate everyone's time today, and we look forward to you joining us on future profit improvement webinars here with Strategic Source. Thanks, everyone, and have a wonderful rest of the week.